Hello, everyone. It gives me great pleasure to welcome you all to this webinar, one of a series of online virtual educational events organized every 6 weeks by the Lebanese Fertility Society. Today's webinar is sponsored by Ferring Pharmaceuticals and lectured by 4 eminent Lebanese doctors. It's the last webinar before our annual meeting, the Life 22, which shall be held at Le Royal Baye in Beirut, September 30th and October 1st, 2022, in which I invite you all to participate. Our first speaker today is Dr. Antoine Hannoun, the founder and director of the In Vitro Fertilization Center at the American University of Beirut. Dr. Hannoun will be talking to us about the benefits and disadvantages of choosing artificial stimulation versus natural cycles when preparing patients for frozen embryo transfer cycles. Dr. Hannoun.
Thank you, Dr. Ghotmi, for this introduction. I will try to share my screen now. Walid, maybe you have to unshare your screen.
No, you're okay. You're okay.
Okay. Okay, so as you mentioned, I will talk about frozen embryo transfer, artificial versus natural cycles. This is my outline, introduction, then the types of frozen embryo transfer cycles, comparison between them, talking about the corpus luteum, its importance, the pregnancy outcome, and then conclusion. It has been known that we have an increase in embryo cryopreservation during the last years. And we have many causes. The first one is the introduction of vitrification. We know that nowadays the best method of cryopreservation, whether for eggs, for embryos, for ovarian tissue, sperm, is vitrification. And even vitrification increased the success rate of oocyte freezing and the fertilization of those oocytes after insemination. So this made to increasing the embryo, the usage among different IVF centers for embryo freezing. Another cause is the single embryo transfer, which is adopted by many European countries and many countries around the world in increasing or encouraging the centers to adopt the single embryo transfer. And by this method, we have many good embryos that are not being transferred, and this increased also the embryo cryopreservation. The third one is the adoption of freeze-all strategy when mainly in polycystic ovary cases, where we use the antagonist protocol and we trigger with the agonist, and we all know that we have to freeze all the embryos. The fourth one is the usage of PGT and the increase in the usage of PGD and PGS, and the application nowadays of the trophectoderm biopsy at the blastocyst stage, which which are forced, if we apply this method, to freeze all the embryos and transfer them in further cycles or in future cycles. And the adoption of the trophectoderm biopsies is when the studies showed us that the pregnancy rate, if we do trophectoderm biopsy, is more than doing day 3 biopsies as we used to do before. The fertility preservation, especially in patients who have a sexual partner or a husband, but they are obliged to, for social circumstances, to freeze all their embryos. And also, many studies have shown that the pregnancy rate after frozen embryo transfer is better than the pregnancy rate after fresh embryo transfers with meta-analyses. And even nowadays, although it was not accepted clinically, but we have many advocates nowadays for freeze-all strategy for all IVF patients. For all these reasons, we have more and more frozen embryos found in our IVF centers all around the world. Now we have those extra or those frozen embryos. What are we going to do with them? Definitely we are going to transfer them back. And what is the best way or type of transferring those embryos? So we have two major types, if we want to say. The ways or the types that depend on natural ovulation or ovulation, and the other type which we do not have ovulation, and divided into the natural, completely natural cycles, the modified natural cycles when we trigger with SCG, and the stimulated cycles when we trigger also with SCG or LH. And these are the group, I will group them under the natural cycles in comparison to the artificial preparation or programmed cycles. We know in the natural cycles, and even if we want to think about how to transfer frozen embryos, we know that we cannot transfer those embryos, this is in general, at any time in the menstrual cycle and we have a pregnancy. The endometrial lining has to be prepared and to accept that embryo, and this needs the action of estrogen in the beginning and then progesterone to prepare the fertilization, to prepare the endometrial lining. Now, in the natural cycles, estrogen is produced by the growing follicles. And after ovulation, we know that we have the formation of the corpus luteum, and that corpus luteum will provide the progesterone. So all is endogenous, prepared by the corpus luteum. In the artificial cycles, we have to give exogenously estrogen to prepare the endometrial lining, and then we continue giving the estrogen, we add the progesterone to reach to the preparation of that endometrium. Now we want to compare between these two different types, mainly the natural type and the artificial or programmed cycle. What are the advantages of artificial cycle? We can plan those cycles, I mean the embryo transfer, because you can choose when to start your progesterone, and accordingly you put your transfer not to be on a weekend, Saturday or Sunday. So this is, we have weekends off, and we can plan when to transfer the embryos. Now this cycle also, it needs 1 to 2 visits. Maybe 1 visit after starting estrogen to assess the adequacy of the follicular preparation or the thickness of the endometrium. And if you are satisfied with that thickness, you can schedule the embryo transfer according to your convenience. So it's 1 or 2 clinic visits at most. Now this cycle or this preparation is definitely easier for the patients not to come for very visits and for the doctors. What are the disadvantages of the artificial cycles? It is not natural. It needs 10 to 12 weeks of medications, because even when we have a pregnancy, we cannot stop the exogenous medications or we will lose the pregnancy. And we have to keep giving the medications till the placenta takes over at around 12 weeks gestation. No endogenous progesterone, and we do not have a corpus luteum, and we will talk about this later. The natural cycles, the advantages is that we have no medications. It's more natural. When we say this is natural to the patients, we have endogenous progesterone, and also we have a corpus luteum. Why we are talking about the corpus luteum? We know that in natural cycles, the corpus luteum will produce progesterone, and we know that progesterone is very essential in allowing the implantation and then in supporting the pregnancy in its early weeks. Also, it secretes estrogen and progesterone, but in addition to this, it secretes many growth factors and many factors that are important for the pregnancy. One of these factors is relaxin. And we know that relaxin relaxes the smooth muscle. It is a very potent vasodilator. And many studies, in vitro studies, showed that this relaxin contributes to cardiovascular and renal adaptation during pregnancy. So the absence of relaxin in early pregnancy will lead to an increased incidence in hypertensive disorders like preeclampsia, eclampsia, and hypertensive diseases. What are the disadvantages of natural cycles? As we mentioned, lack of planning, weekend work, multiple clinics and visits, and less comfort to the patient. And we have 2 things. We have, if we want to depend on the natural cycle without triggering with SCG, we have to determine the day of the LH surge. And we have 2 problems about the accuracy of the determination of the LH surge and which method to use. And we have many studies, and this study here from a meta-analysis trying to determine the ovulation time after determining the LH surge. And you see that it is very variable. And the mean or the duration, it ranges from 20 hours up to maybe 40 hours. And the different studies showed that the mean is 32, 27, 39. So we know that in the natural cycles, when we determine the day of ovulation, we consider this day as the day of aspiration of the follicles. And by determining the day of ovulation, we can schedule transferring whether day 3 embryos or blastocyst embryos. So the day of ovulation is considered as the day of follicle aspiration. So day 3 is put after 3 days and the blastocyst after 5 days from the day of ovulation. Now, if we cannot determine by the LH search adequately the day of ovulation, this might give us a disadvantage concerning the natural cycles. And this is why resort many of us to triggering the ovulation. And by triggering the ovulation, the ovulation will occur after 2 days from the day of the trigger, and hence we can schedule the embryo transfer in a better way. Another thing for the LH search, this is a meta-analysis also by many from many studies from 2007 to 2013 and more. And here they followed they determined the LH in serum, in blood, and from the beginning of the cycle till the end of the cycle. And the observation here is that in 42 to 46 to 48% of the cases, we could determine only one peak of LH, but in 41 cases, we have 2 peaks of LH, and even in some patients, we have a plateau of the peak of LH, and this plateau would last for 2 days, 3 days. And this will give us will give us a wrong estimation of the timing of the LH search. So these are the disadvantages concerning the concerning the, I'm trying to remove one thing from, okay. Another thing is the luteal support during natural cycles. Many of us now if we apply the natural cycle, will supplement the luteal phase with progesterone. Why? Because many studies and meta-analysis showed that if we supplement with progesterone, the clinical pregnancy rate in those natural cycles is better compared without any supplementation, and even the live birth rate is better. Okay. Now we said among the comparison between the different types. Let me see. Okay. Now what about the pregnancy outcome? Please remove this window away from the shared application. Do you see this on the screen, on my shared screen, or you don't see this notice? Walid?
ايه عم نشوفها توني ايه
Please move this window away from the.
شو هيدي؟ ما عم حاول انه شيلها. I'm trying to remove it بس ما عم بتروح. Let me see. I don't.
Doctor, try to stop sharing and then share again.
Okay.
Or read behind the lines.
Okay, I will share again. Share. Okay, maybe this is better. Now we are talking about which one is better. Now, what about the pregnancy outcome from the natural cycles and the artificial cycle? What about the pregnancy rate? I put just the summaries that in 2020 we have a Cochrane review comparing which gives us a better pregnancy rate, the artificial cycle or the natural cycles. And by the Cochrane review, they showed no difference. But in 2021, we have a network meta-analysis, and they showed that the natural cycles gave a better pregnancy rate. What about obstetrical outcome? We mentioned that the absence of the corpus luteum will lead to an increase in the hypertensive disease of pregnancy. But here we have a meta-analysis by Busnelli et al., published in Human Reproduction in 2022. And this is the summary of the obstetrical outcomes. They compared artificial compared to natural. So we have 2 times risk in preeclampsia and hypertensive disorders in artificial cycles. We have 2.5 times risk in postpartum hemorrhage. All these increased risk in the artificial compared to the natural. We have 1.6 times increased risk of cesarean sections. We have increased risk of large for gestational age and macrosomia. We have increased risk in preterm birth and preterm rupture of membranes. So as you see from this meta-analysis, that we have increased risk in artificial cycles in many complications during pregnancy compared to the natural. But here we have to observe one thing. We have to shed light about something. When we say 2 times increased risk, 2.5 times increased risk, what is the real absolute risk? What's the real increased risk? And when they calculated the real absolute risk, they discovered that that risk is not more than 1% of the cases up to 3% of the cases. So in absolute figures, we do not have really that increased risk in artificial cycles for those complications. Conclusion. So the evidence now tells us that we have to go back to natural cycles, or we have to maybe all of us utilize the natural cycles, because we have the corpus luteum, because one of the meta-analyses, one of the studies showed that the natural cycle has better pregnancy rate compared to the artificial, and that we do not have those complications or increased risk of all these complications. But we have to put some questions. Should we really apply this to all? So we are losing the benefit of the artificial cycles, the ease to the patients, the scheduling, the planning. This is one question we have to ask. Another question, can we apply this to all? Can we apply to all patients, the artificial, the natural? What about polycystic ovary cases, elderly patients whom we cannot really have ovulation? Is the pregnancy rate really better? So we have one Cochrane review which showed no difference in the pregnancy rate. And we have the other review that showed that the natural is better. Do we need more studies to really know that if one is better than the other? Is it clinically relevant when we talk about the risks or the complications in artificial cycles? If we look about the absolute risk, it's not really that much. And is it practical to apply? Is it practical to apply the natural cycle for all patients with the less comfort and freedom for all? So the answer to all these is that we need more studies. And maybe we have to direct those studies in a way to decrease the risks accompanied by the artificial cycles when we are at the same time taking the advantages of the artificial cycles. Thank you.
Thank you very much, Dr. Hannoun. As I can see, we don't have any questions from the audience. As Dr. Hannoun said, most studies comparing artificial cycles, modified natural or natural cycles have failed to find any difference in implantation or clinical pregnancy rates. However, current evidence is rising concerning the association between artificial cycles and obstetrical complications like bleeding, C-section rate, and hypertensive disorders, as well as the increase in birth weights. In addition, a recent Swedish group raised the fear from an increased risk of juvenile cancers after frozen embryo transfer, whether it is through natural or artificial cycles. This is why our next speaker, Dr. Shadi Faqih, Director of Al Hadi Medical Center in Lebanon, has the task of discussing current opinions with regard to whether freezing all embryos should become the practice or whether we should keep our practice of doing fresh embryo transfers. Dr. Faqih. Dr. Faqih.
Hello, Dr. Walid, تسمعوني? Are you hearing me?
Yes, we are hearing you, Dr. Faqih.
Okay. So, good evening, everybody. Before starting this talk, I would like to thank the organizers for this very nice invitation. I will mainly focus in my talk on freeze-all strategies and assisted reproductive techniques. And this is how my talk will be divided. In the first part, I will discuss the rationale behind freeze-all. In the second part, I will try to summarize some studies on subgroup analysis that may benefit from freeze-all more than the others. And the third part, how to do freeze-all. It was well discussed by Dr. Hannoun, so I will skip it. So, why freeze-all? Because we know well that the endometrium in natural cycle, it is not the same thing in stimulated cycles. Why? Because in stimulated cycles, we have a supraphysiological estradiol and progesterone level. And this could cause an impairment for placentation, also an impairment for implantation. But it is not only a question of estradiol and progesterone level. Also, we know well that in the stimulated cycle, progesterone receptors are more expressed in both stroma and glands in the endometrium, but also estrogen receptor is also less expressed in both stroma and the glands. And all these modifications may induce what we call endometrial advancement. And we know well that endometrial advancement is very detrimental for ICSI outcome. And this was well demonstrated first in 1997 by Ubaldi in a study published in Fertility Sterility. According to this study, when we have an endometrial advancement of more than 3 days, this may lead to 0% pregnancy rate. But we should mention that in the study of Ubaldi, the number of eggs collected were between 13 and 15 oocytes. The same results were reproduced by Collibian-Akis in Fertility Sterility in 2002. Also, according to Collibian-Akis, when we have an endometrial advancement of more than 3 days, this may lead also to 0% pregnancy rate. But both these studies evaluated the endometrium by pathology, and this is an old technique. With the beginning of the era of endometrial gene profiling, a study appeared in Molecular Human Reproduction in 2005. According to this study, where they compare endometrial gene expression between natural cycle 7 days after LH surge and stimulated cycle 7 days after HCG surge, they found at least 200 gene difference expression between simulated cycle and natural cycle. Another study appeared in Human Reproduction in 2011, where Labarta divided oocyte donors between two groups. A group with a progesterone level more than 1.5, and another group with a progesterone level less than 1.5. According to this study, they found at least 140 genes up or down regulated difference between the two groups where the progesterone were more than 1.5 and where the progesterone were less than 1.5. But also in the study, the number of eggs collected from each donor was between 20 and 23 oocytes. So we are dealing with patients with high responders. So as first take-home message, in stimulated cycles, we have supraphysiological level of estradiol and progesterone. We have overexpression of progesterone receptor, underexpression of estradiol receptor. We have a difference in gene expression inside the endometrium. We have a reduced implantation capacity and impaired placentation. So when should we do freeze-all? And assisted reproductive techniques, we can consider many subgroups. A subgroup where we have a high risk of hyperstimulation syndrome. We can also consider all patients together. We can also consider these patients according to the number of eggs collected. Also, we can divide them also according to progesterone level on the trigger day. Okay, we can consider also patients with implantation failure, patients undergoing pre-implantation genetic testing, patients with slowly developing blastocysts, and patients with high risk of obstetrical and perinatal complications. First, what about patients with high risk of ovarian hyperstimulation syndrome? How to predict these patients? A study published by Riesinger in 2016 have well demonstrated that we have two main criteria to predict ovarian hyperstimulation syndrome. The first one, when we have more than 19 follicles measuring more than 11 millimeter on the day of STG. And the second one, when the estradiol level is more than 6,000 on the day of STG. And when we combine these two criteria together, we can have a negative predictive value for ovarian hyperstimulation syndrome around 100%. A study appeared by Paul DeVroy, taking into account these two criteria, have well demonstrated that when we apply freeze-all to all patients with high risk of ovarian hyperstimulation syndrome, we can have an OHSS equivalent. So probably yes, for safety reasons, we should apply freeze-all for patients at high risk of ovarian hyperstimulation syndrome. Now, can we apply these strategies for all patients? A meta-analysis appeared in 2013, Infertility Sterility by Roque et al., combining the results of 3 RCTs, have well shown that when we apply freeze-all for all patients, we may have more clinical pregnancy rate and more ongoing pregnancy rate. But 2 years after, the first RCT was retired from PubMed, and they reconsidered the analysis de novo. They didn't find any difference between fresh and frozen cycle in terms of clinical pregnancy rate and in terms of ongoing pregnancy rate. In 2017, a meta-analysis appeared in Cochrane database. According to this database, whether we transfer our embryo at day 3 or at day 5, they didn't find any difference in live birth rate between fresh and frozen embryo transfer. So if we have to conclude, probably we should not apply freeze-all for all patients. Now, what about when we consider these patients according to the number of eggs collected? In 2017, a study by Roque et al. Have randomized patients collecting between 4 and 9 oocytes between 2 groups, fresh transfer or frozen embryo transfer. And they didn't find any difference an implantation rate and pregnancy rate, and a clinical pregnancy rate, and an ongoing pregnancy rate. But when he took patients collecting between 10 and 15 oocytes, he randomized them between two groups, fresh and frozen embryo transfer. He got better implantation rate, better pregnancy rate, better clinical pregnancy rate, and better ongoing pregnancy rate when we do freeze-all. So probably when we have a suboptimal number of eggs collected between 4 to 9 oocytes, there is no benefit for freeze-all. And when the number of oocytes collected are between 10 to 15 oocytes, it's better to go for freeze-all. Another study by the same group in ultrasound in 2017, taking only patients, only poor responders according to Bologna criteria. Also in this category of patients, they didn't find any difference in clinical pregnancy rate and an ongoing pregnancy rate. So what about patients with risk, what about PCOS patients? A study in China published in the New England by Chen et al. On more than 1,500 patients randomized between two groups, fresh and frozen embryo transfer, found that with frozen embryo transfer, we have at least 70% increase in live birth rate and 42% decrease in miscarriage rate. So patients based on ovarian response, yes, it is a good criteria to go for freeze-all. Now, what about progesterone level at the day of triggering? A study also by et al. In 2015 randomized the patient with a progesterone level more than 1.5 into two groups, fresh embryo transfer and frozen embryo transfer. And when he adopts this strategy, when the progesterone level is less than 1.5, he go for fresh embryo transfer. And for all patients with a progesterone level more than 1.5, he go for a freeze-all. He got 73% more pregnancy, more implantation rate, and also he got more ongoing pregnancy rate. Another study published in Fertility Sterility, also in 2017, taking into account a threshold of progesterone 1 at the day of HCG triggering, also didn't found any benefit for freeze-all when the progesterone level at the day of triggering was less than 1. But when the progesterone level was more than 1, they got more clinical pregnancy rate, more ongoing pregnancy rate, whatever at the age of the patient, less than 35 or more than 35. So if the progesterone level at the day of triggering was less than 1, we have no benefit for freeze-all. And when the progesterone is more than 1, these patients may benefit from freeze-all. But till now, we cannot consider this criteria a good criteria to go for freeze-all because we lack some evidence concerning these studies. What about implantation failure? Concerning implantation failure, we have two studies. One in US by Shapiro et al., another one in Egypt, published in Fertility Sterility in 2017. According to these two studies, patients with implantation failure may benefit from a freeze-all, but also we lack too much evidence because we have only two studies with small sample size. So probably these patients may benefit from freeze-all, but I put here a question mark because till now we don't have too much evidence. What about patients undergoing pre-implantation genetic testing? We have a good study published in Human Reproduction, randomizing patients undergoing pre-implantation genetics testing into two categories. The first one, fresh embryo transfer at day 6, and the other one, freeze-all at day 5, and then go for frozen embryo transfer. According to this study, they got better ongoing and live birth rate in patients undergoing freeze-all at day 5, with 15% increase in live birth rate. So probably patients undergoing pre-implantation genetic testing to synchronize between the endometrium and the embryo, it's better to go for freeze-all. And this is mainly due to slowly developing blastocysts. Here we have a very interesting study published in the British Journal of Obstetrics and Gynecology. In this study, when they had embryos not reaching blastocyst stage at day 5, they leave them until day 6 and feed them at the blast stage. And then they transfer them at the frozen cycle to synchronize between the embryo stage and the endometrium. And they got better result when they do freeze-all for slowly developing blastocyst. Now, what about obstetrical complications and perinatal outcomes? We know well that patients undergoing assisted reproductive techniques have more complications and more obstetrical complications, and this is mainly due to epigenetic modifications of the embryos. Here we have in this study, they have shown that patients undergoing fresh embryo transfer have more preterm delivery, more low birth rate, more small for gestational age, while patients undergoing freezing embryo transfer have more hypertensive disorders, more large for gestational age, more high birth rate, but less ectopic pregnancy. And this study, another study, have well demonstrated that when we go for frozen embryo transfer, we have less ectopic pregnancy. But we cannot take into consideration this criteria to reduce obstetrical complication. So we should not apply freeze-all for all patients. Why? Because freeze-all may increase the cost of the procedure, may increase the workflow in the laboratory, and may increase also the time to get pregnant. But we should do it for patients at high risk of ovarian hyperstimulation syndrome, for sure, for safety reasons, for hyperresponders, because we have an impairment in the endometrium, for patients undergoing pre-implantation genetic testing, and mainly if we don't get the result at day 5, we should transfer at day 6 in the morning to synchronize with the endometrium. It is better to go for freeze-all. Concerning progesterone level and implantation failure, probably yes, we have a benefit for freeze-all, but we need more evidence. I just want to mention here that a large part of these slides were inspired from a study published by Rock et al. And GBRA Assisted Reproduction Journal. Thank you.
Thank you, Dr. Faqih, for this beautiful lecture. It seems a freeze-all strategy doesn't seem to result in higher pregnancy rates than fresh transfers, except in selected patients. On the contrary, there are alarming reports that frozen thawed embryo transfer may be associated with more obstetrical complications. Furthermore, a recent Chinese study in September 2021 suggested that prolonged embryo freezing may be associated with decreased pregnancy rate. And currently, now, more recently, a new dilemma is arising nowadays following the abortion bans in the United States, namely whether this law shall affect IVF practice, including genetic testing, discarding unemployed or undesired embryos. We still don't know. Our next speaker is Dr. Michel Jabbour. Dr. Michel Jabbour is professor of urology at St. George Hospital, and he's a consultant urologist at the Emirates Health Group in Dubai. Dr. Michel shall address the controversial topic of varicose veins, their effect on fertility, and the current pertaining surgical practices. Dr. Jabbour.
Good evening. Thank you, Walid and the Society for inviting me to this beautiful webinar. It's always a pleasure to be with you. Can I share my screen, or you want to put the slide on your side?
You can share it.
Yalla. Okay, so I believe this is me. All right. Okay. Can you see my my screen? Is it okay?
Yes, it is okay.
Perfect. So as Dr. Ghutmi said, I would like to talk about the controversy around the varicocele surgery. We know that we have as many advocates of varicocele opponents to the surgery. We know that we can see both extremes. Urologists on the side who want to operate on everybody with the slightest varicocele, and gynecologists on the other side where they're refusing surgery even for high-grade varicocele. So I'm trying to gather some objective information around this topic, because we are living it on a daily basis, and the fertility and subfertility issues. So let's go to basic and give a definition on what varicocele is. It's an abnormal dilatation and tortuosity of the internal spermatic veins within the pampiniform plexus of the spermatic cord. This finding is really common in normal males, and it's getting more and more common with the new lifestyle, new social habits. It definitely plays a major role. However, it is not clear enough in subfertility. Why is that? Because we know that, and it's evidence that almost 85% of men with varicoceles have already fathered children. So what is the role of this pathology if 85% of people having this pathology can still father children without even assisted fertility? So the questions that are looking for answers are: what is the impact of varicocele on testicular development and well-being? Is it really an independent risk factor of infertility? And should we operate varicocele? Never operate, always operate. And when should we operate varicocele? So as epidemiology and pathogenesis, it was considered a congenital lesion by some. However, what we can say is definitely we do have a genetic predisposition for varicocele. And we know that the risk, if we have a first-degree relatives having varicocele, increases 4 to 8 times. However, a genetic predisposition alone is not enough. So it's a combination of the predisposition and the acquired environment and the lifestyle. So it is acquired through age due to obesity and sedentary lifestyle, and people like who are, because of their job, standing most of the time, like a policeman, like chefs, like teachers, etc. So it's rarely diagnosed before the school age in boys and mostly appear after the age of 10. So it's not true that varicocele cannot be found pre-pubertally. We have varicocele pre-puberty. However, it rises steeply after puberty, and the prevalence in adolescence is usually up to 16%. However, in the adult population, it is way more frequent because it increases with age, and it can reach 43% according to some studies. Varicocele left or right, we know very well that most of the time it is on the left, and it's due to the drainage, to the venous drainage spermatic vein that goes to the left renal vein instead of the inferior vena cava. And sometimes we do have the nutcracker phenomenon between the aorta and the superior mesenteric artery. However, bilaterality is seen more and more. When we were students, they used to consider bilateral varicocele a rare phenomenon. Now it's not as rare as before. It can be as high as 50%. And this is due to the improvement in the color Doppler technology. One word is, what is weird is whenever we have isolated right side varicocele, and there we need to do some imaging to make sure we don't have erythroperitoneal obstruction of that spermatic vein going to the IVC. So how does varicocele present itself? We usually have three common scenarios. One is couples seeking fertility, married for like a year or less or more, and they cannot conceive. So they come to seek assessment, and we find varicocele. Or it is discovered during a routine exam by family doctors or pediatricians at schools, and we are having this more and more because these family doctors, GPs, and pediatricians are more aware on the prevalence of varicocele at this age. Or testicular pain. Okay. Symptoms are usually nothing in most of the time, so no pain. Pain is only present in almost around 10%, or edema and swelling. So it's not pain in most of the cases, all right? It's either coming for infertility, or sometimes the guys that are more educated now and aware, they palpate themselves and they find a bunch of veins around their testicles. How do we classify the varicocele? I see a lot of description, grade 4 and grade 5. We don't have that. The grading, the official grading system of varicocele is up to grade 3. The grade 0 is where it is not palpable, and we only detect it on Doppler ultrasound, and it's what we call the infraclinical varicocele. The grade 1 is whenever the veins are palpable, when we ask the patient to bear down and do the Valsalva maneuver. Grade 2 is whenever they are palpable, even without Valsalva. Mind you, all this should be done in the standing position. We cannot examine males for varicocele in the supine position. And grade 3 is whenever the varicocele is really visible, so we can see from outside. So we inspect before palpating, and we see what we call a bag of worms. We see it's like a bag of worms around the testicle. That's grade 3 varicocele. What is the effect of varicocele on the testes? We do have evidence, a lot of evidence, that varicocele may alter the testicular growth, especially when it comes in the adolescent period, okay? And hypertrophy is detected in up to 70% in adolescence and puberty. It can alter spermatogenesis. It can definitely alter fertility potential. And recently we've discovered that it alters also androgen production. So it's not only spermatogenesis that is affected by the varicocele. All that is through an increase in testicular temperature and reflux of toxic radicals, which you all know. Definitely the grade of varicocele is directly proportional to the degree of damage, because the larger the vein, the more blood is refluxing, the more toxic radicals are refluxing, and the more damage we can find at the level of the testicle. Why do we operate on varicocele? To catch up some growth. We have evidence for that. We have evidence that the left testicle being hypotrophic compared to the right one can catch up in size in 32 to 83% of the patient after left varicocele surgery, okay? We previously believed that catch-up growth only occurs in early adolescent, less than 14 years of age. Now we have even documented catch-up of growth even in adulthood, according to the gastro, okay? And the testicular growth is documented as early as 6 weeks post-surgery. So why do we operate? In 90% of the cases to recover or preserve testicular function. As I said, we don't operate usually for pain. Pain with varicocele is usually managed by medication and lifestyle management. Okay, we reserve surgery for pain in less than 10% of the cases, and mind you that pain is only relieved in 68 to 88%. So we should be very reserved when we promise the patient who's coming to be operated for pain that his pain may not disappear after surgery. We operate if we have significant testicular a hypertrophy, a reduction in size more than 20%, if we do have a significant abnormal semen alteration, if we have a high grade, the bag of worm, grade 3 varicocele in the adolescent period where the development of testicle is still going on, and if we have significant evidence of hypogonadism. We know that before the age of 17, the semen quality is not something to rely upon, and that's why I said the high-grade varicocele is an indication to operate even without an evidence of sperm alteration in the adolescent year. Unfortunately, no test to date was able to establish a cause-effect relationship between varicocele and oligoastenospermia. There's no direct test that says, well, we have this alteration in sperm quantity and quality because of varicocele. All what we can do is establish a link. There is an association. This patient might have varicocele, high-grade varicocele, and oligoastenospermia without any other obvious cause. So if we don't have any other obvious cause, it's very reasonable to associate the alteration in sperm quality and quantity to the presence of varicocele. So we do have evidence that operating varicocele can improve the sperm quality and quantity, and we have here these studies where initial sperm concentration 43 million was increased to 60 million 1 year post varicocele surgery, and another study where 49 million was increased to 74 million after surgery. However, the downside of these studies is that the numbers were small and there was no mention of pregnancy rate. After all, what we are seeking is not to register numbers, but to get pregnancy. If we need to operate, how can we operate? Definitely there is an embolization, and I'm not going to speak about embolization, which is very en vogue in Eastern Europe. The Western European and Northern American school is not very fond of embolization. That's why we did not receive any training on embolizing varicocele. So what we do, we surgically ligate the concerned veins, and the technique that is most effective is the low inguinal microsurgical technique, which helps really preserving the artery and the lymphatic drainage. It does have a high rate of success and low recurrence, and of course low risk of hydrocele because we can see the lymphatics and spare them. It has to be done under 25 grade magnification. The recurrence, the persistence, and the hydrocele rate is very low. The problem with this technique is time consuming because we need to do it under a high magnification microscope. If there is a risk of testicular atrophy, the risk is way lower than any other technique. What about laparoscopy? Laparoscopy, we are recreating the high ligation of Palomo, however, with a lot of refinements. Why is that? It's because we can see, detect, and spare the artery, and spare and detect and spare the lymphatics. So in laparoscopy, we have a beautiful image. We can clip separately each vein. So this is where laparoscopic varicocele differ from the high ligation, the Palomo all technique high ligation. However, still we are tackling only one bunch of veins, which is the spermatic, and we cannot tackle the other veins that may diverge before the internal inguinal ring, meaning the external spermatic, etc. So does varicocelectomy improve fertility and increase pregnancy rate? Definitely it is controversial. In a Cleveland meta-clinic analysis on varicocele surgery, it was found that varicocele surgery increased the odds of spontaneous pregnancy by 2.87 compared to medical therapy or no therapy. And that pregnancy rate was 33% for surgery versus 15%, the double versus 15% for controls. So we have evidence here from a Cleveland clinic that varicocele surgery does affect pregnancy rates. What's most important in this era is that varicocele surgery improves also the success rate of IVF ICSI. We all know that what we do in ICSI, we are choosing the sperm according to what we see. I mean, we see the most handsome and the most active sperm moving forward, and we pick it up and we use it for ICSI. Still, there are lots of things we don't know when we choose. We choose only on the shape of the sperm. So if the person has varicocele and we have oligospermia, severe oligospermia, operating these patients before the ICSI may improve the success rate of our ICSI. As we see here, operating varicocele significantly increased the pregnancy rate. Okay, the odds ratio is 1.6. We have a higher live birth rate with an odds ratio of 2.17. Gocke concluded that varicocelectomy should be offered before ICSI to infertile man with a clinical varicocele. And I'm going to go back to the term clinical varicocele. We have evidence that pregnancy with ICSI post-varicocelectomy was 62% versus 47% without operating the varicocele, and the live birth rate was 47 versus 29% without operating the varicocele. What about varicocele and hypogonadism? We know that microsurgical varicocelectomy improves testosterone level. Okay, the testicular Leydig cell function is also disturbed with the heat and with the toxic radicals accompanying varicocele. Definitely, this is not the first sign of varicocele. We see first an alteration in spermatogenesis, and with the long-standing varicocele, we start seeing hypogonadism and effect on Leydig cells. We see in this multitude of studies that the low inguinal microsurgical varicocele improved the testosterone level. We see at the last column here is the change in the testosterone level. It's really very significant before and after surgery for hypogonadic patients. Well, when we use the non-microsurgical varicocele technique, there is a rise. However, the rise is not that important because in most of these non-microsurgical varicocele, the artery is sacrificed. We know that we have 3 arteries, and as long as we keep the differential artery safe, we have the right, let's say it's an old story, we have the right to ligate the 2 others just to prevent recurrence. However, after all, we are ligating 2 out of 3 arteries to the testicle, and it will definitely affect the good functioning of the testicle. So trying to preserve the arteries will have a better job when we do varicocele. So you rarely find new articles on varicocele. You go search the PubMed, you go search the Google. It's rare to find new articles because apparently this is a topic that has become a kind of established, although I believe there are still things to be known about varicocele and to be done. In this Spanish study, it was concluded that surgery indicated in the case of grade 3 varicocele, so the varicocele that is seen through the scrotal skin and considered as bag of worms without the Valsalva, or in the case of atrophy and growth arrest, when the difference in size between right and left is more than 2 cubic centimeters, and or when it is accompanied by pain and alteration in spermiogram in young patients. What about pain? Shall we operate for pain? And whether there is pain or not, will the result be better? The answer of this nice study is not. Pain, however, is present, was found more in younger population, okay? But whether pain is present before surgery or not has nothing to do with the answer to varicocele, the response to varicocele on spermatogenesis and spermiogram after surgery. This is an interesting thing that can open some doors to more studies. It's a nice study on the concentration of calcium and magnesium in the seminal fluid. And it was found that it was low in subfertile men with varicocele. And then when we operate these patients and after surgery, the calcium and magnesium concentration will rise again. That could be something new and interesting to work on in the future. My take-home message is the following. Varicocele is definitely a common finding, however, in both fertile and subfertile population. Varicocele, in some studies, the prevalence of it is like 40 to 70% of the population, and we're not going to end up operating on 70% of all men. There is no one test or several tests that can determine whether varicocele is an independent source of infertility. We know that it's a major cause of secondary infertility. While it's not really very known in primary infertility, when somebody has already one child or more and trying to conceive, what we call secondary infertility, varicocele and male factor here play a major role. We should definitely differentiate between what we call significant and non-significant varicocele. We should not operate on any small varicocele because the damage caused by the minor varicocele is really minor. And if we're going to operate to stop a minor event, the response, the success, and the benefits goal is going to also be minor. We examine people and do Doppler in the standing position. We are looking for reflux and we are looking for veins that are more than 3 millimeters. So when they are refluxing, the amount of blood coming back is really significant. And the last word, that microsurgical artery sparing low inguinal technique definitely has the best results compared to the others. And for that, and thank you so much.
Thank you, Dr. Jabbour. You cannot argue with a urologist. For us, gynecologists, it's still very controversial whether grade 1 or 2 varicocele repair improves male infertility.
I totally agree. That's what I said. I agree with you. It does not improve.
We have 2 questions from the audience. One from Dr. Shaban asking, what about repeated varicocele surgery? And one from Dr. Salim Mugharbil asking, varicocelectomy for azoospermic or very low counts for infertile couple. I don't know if I understood the question. Conduit à tenir. It means, is it a practice to maintain or not?
Yeah. For Dr. Shaban, the question is, again, say the question of Dr. Shaban.
What about repeated varicocele surgery?
Yes. Yeah, that's an everyday question that we have, because we see patients operated for varicocele, especially in the old technique, and we have persistence, not only recurrent varicocele. So when they came to us, we still feel varicocele. So if we feel the veins, that does not mean they are refluxing. And if we do the Doppler and they are refluxing, that does not mean that they need to be operated. Here, we really have to judge the same way, even more, with more scrutiny, to decide on reoperating the varicocele. And usually, a reoperating varicocele does not have that nice result in our eyes compared to when we operate varicocele in the first place. As far as Dr. Mgharbani, there is not one study, several studies showing that when we operate high-grade varicocele in azoospermic males, there is a certain percentage, I don't have the number in my head now, but there is a certain percentage that will have spontaneous sperm emission. So we can do that to facilitate the ICSI later on, so we can take the sperm for ICSI instead of doing TESA or micro-TESA for the procedure.
Thank you. Now, in the absence of any other questions from the audience, I shall skip to introduce our last but not least speaker, Dr. Imad Abu Jawdi, who is the head of the IVF department at Abu Jawdi Hospital, who shall speak to us about new evidence with regards to the role of endometrial factors in recurrent implantation failures. Dr. Abu Jawd.
Thank you, Walid. Thank you for the organizer to let me share with you my presentation. So as said Walid, so we'll talk about implantation failure and new things in this field, some updates. As you know, implantation is a complex process where many things get inside. I will not go into details. If we take the reason of implantation, you have many reasons: possibility of non-fertilization and fertilization, and a possible pre-implantation loss going around 50%. This is a natural cycle. And if we go to the different reason of implantation failure, you have the tubal factor, the uterine factor, the embryo factor, and the male factors. So we'll focus essentially on the uterine factor, and we'll go in details one to the others. In IVF, the failure is usually due to the embryo. As you know, the aneuploidy is the reason of 50% of non-pregnancy during IVF, and the implantation is considered around 20 to 30%. The male problem 10%, and the unknown factor around 10%. This is a very interesting study from Pirtea and the group of Scott, and they found when we put an euploid embryo, they have 60% pregnancy, but they still have 30 and 40% of non-implanting embryo. But when you do three transfer, you have around 90%. So this means that even if you put an euploid embryo, you still have 40% you will not implant. This is very interesting study. Will make a change in IVF.
ليك الكونفرنس تبعيتي شكلها مطولة وأنا المضبوط بلشت أنعس.
لازم تسكروا له mute him please.
Dr. Michel, please mute.
So we'll talk, this is the plan of our subject. We'll talk about age in implantation. We'll talk about mechanical factors, about endometritis, about the window of implantation with the transcriptome, the ERA test, or the WIN test, the French one. A very new concept of ultrasound, the compaction, and we'll show you some new results, and the immunology. The age, it's not all about oocyte aneuploidy. It's also about the detrimental age, and the uterus also get old. This is a new concept. When we put euploid embryo, even after 35, we see a decrease in pregnancy rate. So this means that there is an aging problem of the uterus, and the pregnancy is decreasing after 35, even if you put an euploid embryo. And here another study with 8,000 euploid single embryo, and you will have also a decrease and significant decrease in pregnancy after 35 and 40-year-old. Now we'll pass to the mechanical factor. In the mechanical factor, you certainly, this is all of you knows about it: a polyp, a fibroid, a septum, a synetia, and Asherman syndrome, and recently the uterine scar. There is some study which shows interesting finding on it, and endometritis. All these factors are the mechanical factors that we can treat and even improve our pregnancy. There is a question coming: should we do hysteroscopy before all IVF? All these societies said no. We don't have to do previous first IVF and hysteroscopy. Should we do an hysteroscopy after a failed IVF? The study in Turkey found that after 2 failed IVF, a meta-analysis with a study from Gürgen from Turkey and another one, find an improvement in pregnancy. But the most important one is the Trophies trial with 700 patients randomized in 2 groups. If we do hysteroscopy or no hysteroscopy, and we see that there is no improvement in pregnancy rate if we do hysteroscopy for all our patients after failure of IVF. So I think actually if you have a good ultrasound, you can screen your polyps, your synetia, or your septum, and even if you do 3D ultrasound, and if you want to do in sonohysterography, you can easily have a good diagnosis, as good as the diagnostic hysteroscopy. Okay, so we don't need to do hysteroscopy for all our patients after failed IVF. If you do a good ultrasound, you can have a good diagnosis. This is a polyp. You can see it sometimes not easily. You put some water and you see it on hysterosonography. This is on hysteroscopy. So hysteroscopy should be only for operative cases. For polyp, this is a study. There is no randomization, but this is an important study that we find that the increasing of pregnancy when you remove the polyp and with hysteroscopy. A fibroid, the same. There is a meta-analysis showing that when you remove your fibroid, the submucous fibroid, you have an improvement to 3 times more pregnancy if you remove your fibroid into the cavities. Okay, the uterine septum, this is a big, still a big discussion. There is a people saying that if you remove your septum, you will have an improvement in your pregnancy rate. And another study, an important randomized study from Holland, and a randomized study showed that there is no advantage to do a septum. Maybe this is still debatable, and maybe a symptomatic septum should be removed, and maybe keep the septum, not for all the patient to remove the septum. If you have a synetia, there is an important review on 5,400, 6,000 women. There is an improvement to the 50% pregnancy when you remove your synetia, but attention, you will have placenta accreta in a proportion of 10%. Like uterine scar defect, the preliminary study showed that there is an improvement in pregnancy, but this study didn't look to the kind of if it was symptomatic or no. A new meta-analysis recently published found that there is no improvement in the pregnancy rate, but there is an improvement into the symptoms. So when you remove the scar or the niche, you will have less bleeding, but there is no improvement in pregnancy. Okay, so they say that it's actually not advisable to do it to improve your fertility. Maybe if there is symptoms, but it's not clear in the study if they're symptomatic, if they have an improvement in their pregnancy. Certainly, this is very old and it's not new. When you have hydrosalpinx, you can remove them or you can cut them. And if you have difficulty to operate, you can coagulate the tube by hysteroscopy, or you put the Assure that we don't have in Lebanon, but it's possible to bring them. This is a possibility to block the tube and to improve your pregnancy. The chronic endometritis is a très à la mode actually, and when I was resident in Paris with Friedman and Amou, I was working with him, and he told me, you see this red spot, this is endometritis. He gave them antibiotic at this time, and he controlled them 2 months later, and it disappeared. And there was an improvement in the pregnancy at this time, but the French group didn't publish them. They have only a small publication in a French journal, and it wasn't very important. Recently, Cincinnati in 2005 described also the new criteria, and especially this micropolyp. When you see this micropolyp, it's 100% you have chronic endometritis. And in 2016, the studies of the diagnosis by anatomopathology, and you do the CD138. And when you do the CD138, you see this yellow plasmocyte. This means that you have a chronic infection, okay? Chronic endometritis. So actually the best and the easiest diagnosis is the CD138. And if you are rich and you want to do it by PCR, you can do it, especially the same manner as you do microbiota, or you do the window of your implantation. You can have also the type of your infection by PCR, and you will have the diagnosis of your chronic endometritis. Okay, so this is in hysteroscopy. If when you do it, take care when you see these red spots or the elevated gland. These are signs of endometritis, or this micropolyp like this, and there is vascularization sometimes inside. Okay, so these are signs of endometritis. If you are more interested, you can read the article of Cincinnati, and they have a very good description or different type of endometritis. We have recently introduced in our center this CD138, and I have studies on 39 cases. I have 28% positive cases in implantation failure. We have 38% and miscarriage. In implantation failure, around 15%, and unexplained infertility, 20%. I use this Novak cannula in the clinic, and I sent it to the pathologist. And actually, I am happy with the diagnosis because I controlled them after the treatment, 1 month after the treatment. When they took the doxycycline, 90% are cured, and one didn't cure. I add Flagyl, and she cured. If we look to this literature, I compared my result to the literature. These are the prevalence, and this is our prevalence, and this is the prevalence of recurrent miscarriage, and you can see here we have 40%, and in the recurrent implantation failure, we also have comparable results. We have some cases, we compare them by PCR, sent it to Spain, and it was also correlated. This is recommended to treat your chronic endometritis. You give doxycycline for 14 days, and you have 90%. This is what we have. So our results are comparable to the literature. And after, if it is not cured, you give ciprofloxacin and metronidazole, and you have 92%, 99% cure. Okay, so for this chronic endometritis, the cheapest way, actually in Lebanon, we have to go to the cheapest way. This is the immunostain, $40. If you want to do a diagnostic hysteroscopy, it's between $300 and $700, and your molecular biology, $800. So the CD138 is a good test to diagnose your chronic endometritis, and to avoid to do a diagnostic hysteroscopy just to see this chronic endometritis. In conclusion, chronic endometritis is a frequent factor of implantation failure and recurrent miscarriage. We need a randomized study to validate these data, but observational studies are very promising. It's important to describe it when you do your hysteroscopy, and you can replace it with CD138 in your office. Adenomyosis, you all know it, especially when you do your hysterectomy. Actually, with a good ultrasound, you can diagnose it easily, and you don't need MRI only in difficult cases. This is the MRI. You have this junctional zone, which should be more than 7 millimeter. Some say 5, some say 10, but I think 7 millimeter is good for infertility. And in ultrasound, these are the criteria. I will not develop it more. So the impact of adenomyosis on the IVF, yes, there is a decrease in pregnancy when you have adenomyosis, and especially when it's more important than a small adenomyosis. We do a study a long time ago in 2006, and we found also there is no impact on general infertility. There is very important impact in in IVF, and we do our study, which was comparable to what others have found. But in egg donation and our personal data, there is no difference when you have adenomyosis. It's only important in IVF, ICSI, and the fresh cycle, not in frozen cycle. Now we go to more advanced things and the new. The window of implantation. There is two approaches. There is, you can have the genetic transcriptomic error test or WIN test for the French one. It's expensive. It's around $800. And the ultrasound, the compaction phenomenon, cheap and easy, available everywhere. So the window of implantation, what is it? Each patient have an expression of gene in her uterus, and she expressed different genes that are downregulated or upregulated. And when you have these genes, you have the woman is ready to be implanted. But the window is not very large. From the study of the Spanish group of Antonio Pellicer in 2011. So it's very, it's not new. And actually, there is a window. If you are in the window, you are in a good place to put your embryo. Sometimes you are after the window, or you are before the window, and at this time, it's not good to put your window, okay? What's new? What's new is this. The study in 2020 randomized by Carlos Simon and the group of iGenomics. And also they found that if you use a personalized transfer with the window of implantation using the ERA test, you will improve your pregnancy in a person doing her first attempt. The count recently in October 2021, and there is an important randomized study for the first attempt, and finding they randomized ERA test against doing a simple standard time transfer. They found no difference in pregnancy rate in the both group. So actually there is and this article was a simple a simple abstract at the SRM last year. It make a big problem that I will show you in the next slide. When you use your window of implantation after a failed attempt in iGenomics, they said that you have an improvement of 70%, so 16% more pregnancy when you use the ERA test. And recently, from the group of EV, who were collaborative with iGenomics, they found after a failed attempt, there is not an improvement, but a decrease did not improve, but worse outcome were detected when ERA test was used. This is a very recent paper in September 4, so 5 days ago, okay? And when I was preparing my article, it was 7 September, 2 days ago, the end of an endometrial receptive test. This is published in the Fertile Sterility 2 days ago. And after the paper last year of the abstract in the SRM, in the New York Times in January, there is a trial and fraud charge about Elizabeth Holmes' work with iGenomics because they promised the people for a test who was not validated by the FDA. Okay, it was only validated by the Medicare and Medicaid service. And I tried to find at the ESHRE last months that if there is any paper on the ERA test or the window of implantation, I didn't find. So I think there is a big debate actually, and the days are coming, and I think it's possible that it's the end of this test. So ERA test, be careful in using ERA test, not validated by a robust study, and we will see. The ultrasound. The ultrasound, for those who don't know, there is a compaction of your endometrium from the day there is the peak of ovulation, or she took the HCG, or she started the progesterone. After 5 days, there is a decreased progesterone. When you have this compaction phenomenon, you will have a better pregnancy rate than when you have non-compaction. And this paper was presented by the group of Casper in Toronto. And I personally do a same study that I presented 2020 at the ISIOG, and I found the same result. Also, when you have compaction in frozen or donor eggs, we have 50% pregnancy when we have compaction, and you have no compaction, 25%. Comparing in IVF, if you have compaction or no compaction, we have no significant pregnancy rate. And what's interesting is there is actually a meta-analysis, there's many studies, and they found all improvement in live birth rate when there is compaction. And this was presented last month at the ESHRE. And when they combined these data, cycle with endometrial compaction resulted in significantly high ongoing pregnancy and live birth rate, then cycle with no decrease in endometrial sickness support the change in endometrial sickness as an easy, low-cost, potential non-invasive marker for endometrial receptivity. Microbiota. What's microbiota? For the audience, maybe you are not all in IVF, but human nature cannot be pregnant if there is no lactobacillus. So we need microorganisms to grow, and the implantation need this bacteria. And if we have dysbiosis, that means if your flora are not equilibrated, you will decrease your pregnancy rate in IVF. So the paper was, the first study was done by Maidan from Denmark. And I found that if you have a dysbiosis or if you have no lactobacillus, there is a decrease in pregnancy rate, 10% compared to 35%. So it was significant. And actually, many studies have confirmed this preliminary study from Spain and other places. So the question was how to treat. This is a new concept. We treat it vaginally or orally or both, or we don't know. So we present a study in 2018 and at the MEFS meeting, and we found at this preliminary study that if we use lactobacillus, we have an improvement in our pregnancy rate. But this was a small group, and actually we didn't, our new data not published, we didn't find any difference in pregnancy when adding lactobacillus in the vagina. And others showed recently that when you put your lactobacillus in the vagina, only 35% will normalize their dysbiosis when treated vaginally. But if you treat orally with a good diet, there is probably a normalization of your dysbiosis and improvement of your pregnancy rate. So this is the paper presented last month at the ESHRE, and they found only 34% who improve their dysbiosis when we treat them vaginally. And if you treat them orally with a diet, and the special diet directly organized by, you will have a normalization, a better normalization of your vaginal microbiome. The immunology is very controversial issue for sure. There is a place for the immunology. The tests are not uniform, they're still under research, and the treatment are not validated. So I think it's still debatable. In conclusion, implantation failure is an important issue, not the only. After excluding the mechanical factor, endometritis can be easily performed in the clinic. The window implantation can be easily diagnosed by ultrasound, and the microbiota are for sure a reason, but the treatment is not clear whether we have to take it vaginally or arrange your gut microbiota. This is very new, and we have to follow this issue. Thank you for your attention.
Thank you, Dr. Abu Jawdi. When you come to think about it, it's fantastic how we have reached the stage where we can secure a 95% pregnancy rate after 3 attempts of transferring one euploid embryo. The take-home messages here after Dr. Abu Jawdi's lecture is the strongest among all this evening's presentations, because if you want to practice an evidence-based medicine, then we should all be convinced and stop the malpractice of doing hysteroscopy unless the ultrasound is abnormal. Stop doing thrombophilia profile and immune profiles because they are not evidence-based. Stop giving heparin and aspirin because they are only given empirically. Intralipids and immunomodulators are not evidence-based. And maybe, in contrary to what Dr. Abu Jawdi said, the ERA test, I don't think it has a very high level of evidence to be implemented in practice. The only two tests that are really evidence-based are a karyotype to rule out any translocation and pre-implantation genetic testing to rule out aneuploidy. I just noticed a question from the audience by Dr. Moody Farhat. Is there a relationship between chronic endometritis and ectopic gestation? For Dr. Imad Abu Jawdi.
I didn't have any paper on it. Chronic endometritis is very frequent in infertile patients, but ectopic is less frequent, is around 1%, but you'll have more chronic endometritis than ectopic. I think it's not. I didn't see any paper who relate this problem.
Yeah, maybe it's related to endometriosis more than endometritis.
Mm-hmm.
Thank you very much. It was a nice webinar, and thank you for all the audience.
Shadi, want to ask a question? Refa Idu.
Yes,
I
Dr.
didn't know.
Imad, thank you. Thank you for your
عامل هيك ورفقة.
excellent presentation, Dr. Imad.
Hey, hi, Bushra.
دقيقة
Can I
اسمعي
ask a
شادي.
question?
شادي قبلك.
Are you hearing me, Dr. Imad?
ايه أكيد.
Dr. Imad, about the CD138, you make it by immunohistochemie.
Yes.
You make your biopsy at which day of the cycle?
Any day. Any day. ما في إيه.
Which technique? Immunohistochemie?
Yes, immunohistochemie, yes.
Okay.
Oblige. Classical anatomopathology will diagnose 1%, but CD138, you need the immunohistochemie, obligatoire.
Yes, but do you have a threshold about the percentage of expression of CD138, or just present or absent?
لا, you count how many plasmocytes by immunofield 300 by field. So this is the problem. Actually, you count 1, it's positive, 2 is positive, 5 is positive. Actually, we say that we have more than one it's positive. The definition still, as you see in my table, if you see it, the paper, it's not uniform by the paper presented. Okay, maybe this is why we have a percentage different from place to place.
Okay, thank you.
There is also Dr. Basima Jabir and Dr. Rafa Abu Habib.
Who wants to go first? Shall I go first? Rafa.
تفضلي يلا.
تفضلي, go ahead.
Hey, hi. I want to thank you for this webinar. Thank you very much. Nice lectures. Dr. Imad, for the chronic endometritis, do you think we should, not in implantation failure, in the infertility, idiopathic infertility, actively seek endometritis and treat it? And if yes, which regimen? I mean, you said 400 milligram. That would be 4 tablets, doxycycline for 14 days. Thank you.
The best case I have, she delivered 2 hours ago. I delivered her 8 years ago for a baby, and she got infertile, secondary infertility, and she didn't get pregnant. I do for her IVF last year with excellent blastocyte and everything, and she didn't get pregnant. She's living in Dubai. Before going in Oman, and before leaving, I tell her, let's do the test. Maybe it's positive. And I do the test. It was positive, and I give her antibiotic. And months later, she gets pregnant after 7 years of infertility. So I think there is an improvement, yes, in natural infertility. Yes, the paper are positive for this.
Okay. Thank you.
Thank you, Dr. Rafa. I guess that's it. We can adjourn. Thank you very much, everyone.
يعطيكم العافية.
Thank you, Walid.
Excellent
It was a
workshop.
pleasure
Thank
being
you.
with you.
Hope to see you all
Thank you.
in Live 22 in September 30th and October 1.
يعطيك العافية.
Thank you, everybody. Bye to all.
Bye.